Hi, good afternoon. How are you guys doing? The September exam people, I think 2 months to go. It's on 11th and 12th, right? Sleepless nights, tension, stress. How are you feeling? Just relax, just be focused and consistent on how you're preparing and do not be concerned on what the result would be. It's not in your hands. But yes, choosing the correct answer and solving the question is in your hand. I'm just going to pause this. I'm getting a call. Yeah, hi. So I'm back. uh, Husband had called. He was just asking how I am. It's my off day, so occasionally he calls in the daytime and seeing what I'm doing. Um, yeah, I was just telling him that I was missing home and I wanted to go. So he was like, "Do you want to make a quick trip and come back?" And I was like, "It's raining too much in Bombay at the moment. The flights are getting cancelled or delayed, so and there's like crazy traffic jam because you know how Mumbai rains are. It's not a properly planned city, so there's waterlogging everywhere, so it's always best to stay at home. So yeah, I can't. Of course I can talk to my parents on phone, but I don't know why I was just missing home. So yeah, about that. So let's again solve another SBQ, that is scenario based question of Australia written exam. Today we are discussing about a simple question, but 110% this question is going to be asked in your exam. Like things related to this question, we are discussing about infective endocarditis, the antibiotic prophylaxis required for it, and just as a lateral concept clearing, I am going to share in which conditions antibiotic prophylaxis is required, because this is a very hot topic. I really don't understand. The guidelines are very clearly specified, yet candidates continue to make mistakes. Probably they don't read the entire sentence, or they forget the timeline, or they don't understand some basic stuff about it and make a mistake. So, before jumping on to this question, I would just like to revise a bit of theory so that your concept is cleared. Because once the concept is cleared, then let them ask you 10,000 questions on this. You'll be able to answer each one of them correctly. The problem happens when your concept is not clear. And I do understand that as a freshly passed out graduate, or even as a clinician who's out of touch with theory, sometimes you feel outdated with the concepts, or you just haven't studied them because you were studying other things to clear the exam. But it's never too late to go back to concepts, especially done in a short and sweet manner. So let's do it. So I had opened already few tabs here. Wow, one of them was this. Okay. First of all, let's talk about subacute bacterial endocarditis, which is of concern to the dental practitioners. Why? Because the uh, microorganism causing this is streptococcus, which is the mouth area, and anything that would make the streptococcus bacteria, which is just hanging on to your mucosa, go into the bloodstream and then reach the heart. All these procedures basically which involve blood in patients who already are at risk of endocarditis, they become at risk of subacute bacterial endocarditis. So though we keep on saying subacute bacterial endocarditis, it's very few that I have encountered candidates who actually know what that means. So I thought, let's just, why not open up and discuss about it a little more. So what's the difference between acute and subacute? Why do we call it as subacute? You have heard the terms of subacute, subclinical. What does that mean? So let's see the differentiation. In an acute endocarditis, the symptoms onset to diagnosis is at least 1 week. Even though it's acute, still you see there is a time lag of 1 week. Usually, psychological wise, we tend to think if it's acute, it's like instant or severe or painful, immediately occurring. No, acute usually has a timeline of 2 weeks. After that, it becomes chronic. So 1 week is the timeline for the acute endocarditis. It's like acute malaise, like like a sudden onset of fever, which may happen after 4 days of exposure. Shaking chills, feeling very cold, there's fever, which may be high, there is leukocytosis, that's increase in the WBC cells, normal gamma globulins, rheumatoid factor positive. I'm not going much in the rheumatoid factor, but for you, the important points to remember is that its onset would be like within a week, acute fatigue, severe fever, chills, shaking chills, not just shaking chills. And what are the subacute ones? Symptoms onset to diagnosis is 4 weeks. Weight loss is there. Fatigue, night sweats, low or no fever. You see, the fever is not there or it's very low. Normal WBC counts, or actually it's less, leukopenia, elevated gamma globulins. So, subacute, so for example, a patient came to you and he got the dental treatment done and he was at a risk of endocarditis. And after 4 weeks of treatment, he's calling and saying, I think I'm very tired and I feel night sweats. And you are on the phone asking, but is there any fever? Oh, dude, your treatment was done like 4 weeks ago. No way this is related to this, like, your symptoms are related to the dental problem. Think. If you knew the symptoms, then your alarm bell should ring and you'll be like, okay, you know what, let's not take this jokingly, let's be serious about it and let's just go and get it checked. You understand? So only if you know the symptoms will your alarm bell ring. If you don't know, even you would be like, it's been a month since I saw you. Your symptoms are not related to us. Just don't worry. There's no fever. Just have some multivitamin and relax. No, you should not be doing that because that subacute can create a lot of problems later on. Understand? So, having known this concept, I want to say something else about the prophylaxis part now. So I opened this. This is from the Australian guidelines itself because you people are going to give the Australian exam. I thought might as well open their guidelines instead of taking the standard American Dental Association guidelines. So let's just understand what does antibiotic prophylaxis mean. Okay, antibiotic prophylaxis has been used in dentistry for patients at risk of infective endocarditis or prosthetic joint infection. So two different flow charts of antibiotic prophylaxis when you're going to give. There is a term called as therapeutic prophylaxis. Prophylaxis means what? What does the name prophylaxis means? It's like you're giving something additional to prevent something of which you think may happen, which you think the patient is at risk of. So you're trying to prevent something. It's like you wear a helmet when you are driving on a bike in order to prevent a head injury, which you might be at a risk of. So this antibiotic prophylaxis is like a helmet covering extra precaution. So that is what prophylaxis means. And when you're going to give this, either to patients who are at a risk of infective endocarditis or to patients who had prosthetic joint replacement. Now, there is a timeline for prosthetic joint replacement. It's not like somebody had a prosthetic joint replacement, suppose a knee replacement 2 years ago, you'll still be giving the antibiotic prophylaxis. No, it's a 6 month timeline. If between 6 months the patient comes after having a joint replacement anywhere in the body, you do give him. But if it's crossed 6 months, then you don't. So there is a if attached to it. But to the patients at risk of infective endocarditis, even if they had it once in their life and they're coming to you after 30 years, you still give them. Heart is a very important structure, right? You don't want to mess around with it. So that is what it means. Now let's go to further. What is infective endocarditis, by the way? Who's responsible it? The viridin streptococci. Where are they present? In the mouth. So anything that you're gonna do, which is going to involve toothbrushing, toothbrushing, believe it, flossing, pulsating water irrigators, and interdental wood sticks, they can all produce bacteremia. What is bacteremia? Bacteria in blood. Anything related to mia ending is related to blood. So bacteremia, bacterias in the blood. Gingival inflammation has been significantly associated with an increased risk of bacteremia caused by toothbrushing. However, the incidence of bacteremia with flossing does not differ significantly between people with or without periodontal disease. The incidence and magnitude of bacteremia caused by flossing are the same as that caused by deep scaling. Just imagine that. Flossing bacteremia is same as deep scaling root planing within the same patients. Yet, deep scaling root planing is considered as an invasive dental procedure that has traditionally required antibiotic prophylaxis. So, your flossing is equal to a deep scaling. Of course, the patient cannot be keep taking antibiotics when he's doing flossing at home or toothbrushing at home. But if they are coming to you for scaling, that would be deemed as an invasive procedure because that would create blood. Not create, rather, that would involve blood while scaling because chronic gingivitis, you must have seen even simple type C grade calculus if you have to remove from the gingival sulcus. It causes blood related procedures and yeah, enough to start bacteremia basically. So anything basically that involves even a bit of blood requires antibiotic prophylaxis. Now you may ask, does that mean giving local anesthesia will also cause? So far, giving blocks or infills, you don't have to give antibiotic prophylaxis. Now, for example, if you were doing a simple class 1 filling and you had to give a local anesthesia, you are not going to give antibiotic prophylaxis. But if it's a class 2 filling, remember this, then you're expected to put a matrix band, and that matrix band and the clamp is supposed to go a little bit subgingival, releasing blood from the gingiva. Then even if you're not giving the local anesthesia, it's out of question, you still have to give antibiotic prophylaxis. Okay, my husband's calling again, give me a moment. Yes, I'm back. So yeah, where were we? Class 2, right. Class 2 fillings, if the question mentions the patient is going to have a class 2 DO or MO filling, would you be giving antibiotic prophylaxis if the patient was at risk of infective endocarditis? Yes, definitely yes. Anything that would involve placement of a matrix band, which is going to go gingival, expected to cause a bit of bleeding, and that becomes an invasive procedure. So, yes. Remember, a question like this will come, and that is the time when my voice will be in your head and you have to mark yes. Okay. So, then we move on to, uh, yeah, cardiac conditions for which antibiotic prophylaxis is recommended for dental treatment in Australia. Prosthetic cardiac valve or prosthetic material used for cardiac valve repair. See, one easy way to remember in which conditions of heart you will be giving antibiotic prophylaxis is anything related to the valves. If a question comes, coronary artery stent was given. No, that doesn't require antibiotic prophylaxis. Only things related to the valves. Why valves only? Because in subacute bacterial endocarditis, the bacteria specifically go and start creating problems in the valve area. Hence, if something has already been done on the valve area, it's already repaired or fixed, or it had a defect or still continues to have a defect, that is the site of attack of the bacteria. Hence, you are supposed to give antibiotic to protect that site only. The bacteria apparently for subacute bacterial endocarditis do not create much mess around the other parts of the heart, which are the walls, septum, or the myocardium. It's the valves, those bicuspid, tricuspid, semilunar, all those kind of valves. Okay, remember this. So if the question mentions anything related to the valves, VALVES, please go ahead and give the antibiotic prophylaxis. Okay. So first is there is a prosthetic cardiac valve or prosthetic material used for cardiac valve report. Okay. Previous history of infective endocarditis, definitely a must you have to give. And congenital heart disease, but not all of them, only if it involves unrepaired cyanotic defects, including palliative shunts and conduits. Completely repaired defects with prosthetic materials or devices, whether placed by surgery or catheter intervention during the first 6 months after the procedure, after which the prosthetic material is likely to be have endothelialized. So if something surgery has been done or something has been placed in the first 6 months, then only you have to give antibiotic prophylaxis or else no. Repaired defects with residual defects. So you have repaired a defect, but still a defect has been left or it's adjacent to the side of the prosthetic patch, which will prevent its endothelialization, then you are supposed to give the antibiotic prophylaxis. You have to really mug up this box. Rheumatic heart disease in patients at high risk of endocarditis, that's indigenous Australians. We did discuss about indigenous Australians, right? The other day in another video. Go and watch that. And those at significant socioeconomic disadvantage. Heart transplant patients, consult the patient's cardiologist for specific recommendations. So I hope this is clear. Mug up this box. This box is also given in therapeutic guidelines, all versions, okay? If not, just Google antibiotic prophylaxis recommendations in Australia. You'll come across this article or some other article which will be having the same box. Print it out, write it down, place it on your dashboard, get up in the morning, look at it daily. This is one of those charts which you have to mug up, and you cannot afford to make a mistake, as these questions are very important and they 100% would be a marked question because you are expected to know answers to this. You cannot screw up with the patient, right? So, having known all this, now let's go back to the question. So, what is our question? A 48-year-old patient on warfarin. What is warfarin? It's a blood thinning agent. Which test do you take to measure it? INR, internationalized normal ratio, which is the minimum one, acceptable one. But in patients who are taking warfarin, what is the expected 2 to 3? Remember, write it down, mug up. A 48-year-old patient on warfarin presents with a tender root canal filled upper first molar. Why is he taking warfarin? Probably either for hypertension or he had some heart problem or something related to blood, so that the blood is kept thin and keeps flowing to prevent the formation of thrombus. Understood? The pain is severe and intermittent and it is more pronounced and biting. See, whenever the question says the pain is more on biting, remember some form of periodontitis is happening, and immediately your brain should go to either fracture, cracked tooth syndrome, or some periodontal issue. These three things should be on the top of your differential diagnosis. He had received a prosthetic heart valve 5 months ago. Valve, tube light, plus 5 months, bigger tube light. The tooth is tender on percussion, again periodontal related issue. The radiographical examination showed that the canal is overfilled, but there is no periapical radiolucency. Okay. So when there is no periapical radiolucency, no lesion, but the canal is overfilled, so that extra part may be bothering. But again, let's see what the question is. Based upon the radiograph and the symptoms, the most likely diagnosis for the condition of the first molar. This is my first molar. I just see a root, I don't see a crown. Probably there was a post core which came off with the crown. But what I do see is the gutta percha is going extra, and I have the history that there is pain on biting. So when I see something like this and I don't see a lesion here, I cannot say there is a cyst or a granuloma. And acute periodontal lesions will never be seen on the X-ray. Acute periodontitis needs 2 to 3 weeks to reflect on the X-ray. But the clinical symptoms are there. So what would be my diagnosis? Granuloma? No. Granuloma takes weeks to develop and there would definitely be a radiolucency. Fractured root? I can't see one so far. Periapical periodontitis, apical scar, and apical cyst. Scar, cyst, no. Only periodontitis, right? Periapical periodontitis. I just explained that is my answer of choice. Yeah, don't get confused seeing this periapical lesion. It's on another tooth, and the question is asking your diagnosis about this tooth. Had they been asking about the diagnosis for this premolar, we could have written granuloma, cyst, lesion, whatever. But for this, it's just apical periodontitis. Now, the patient records showed that he's not a regular attendee due to living in a regional area. The recommended treatment in this case, see, not a regular attendee. That's the key word. Here, we are not trying to see what is the best for the tooth. We are trying to see how can we relieve the pain, knowing the patient may not come back if we give them a treatment involving multiple settings. So basically, we have to get rid of his pain in one session only. So then there's no other option but to do extraction, because doing a re-root canal and putting a crown over it will require 2 to 3 sessions. And the patient is not a regular attendee and he wants his pain to be relieved. So the best option is extraction. Restoration not possible without treating the root because there is periapical periodontitis. Root canal retreatment, good option but not possible. Antibiotics may not help, they'll help for just a certain time. Root canal retreatment and restore with post and core, ideal treatment but cannot be done because of the situation of the patient. So when you read a question, see the keyword. A lot of you will jump onto root canal retreatment and restore with post and core thinking this is the best for the tooth. No, you have to think what is the best for the patient, even if that means sacrificing a tooth. Understand? The patient had a prosthetic heart valve replacement done 5 months ago. Is he at a risk of infective endocardits? Yes, definitely. And when he would be needing the antibiotics, preoperatively, always preoperative. But yes, there are times when you do give antibiotics postoperatively. It's not contraindicated. It's just that it's no longer recommended. You have to understand the difference between no longer recommended and contraindicated. Contraindicated means you cannot give at any cost, as in no matter the situation, you cannot give that medicine. Not recommended means usually you don't, but there are situations where you can. You understand? So in this scenario, if I have the option, it's needed preoperatively, I'm going to go with that. It is mandatorily needed postoperatively, no. So I'm just going to go with option C. The primary consideration during treatment of this patient is, see, in any patient having a systemic problem which involves blood, like leukemias, hemophilias, cardiac problems, valve problems, prosthetic joint problems. What is the consequence of your dental treatment? You don't want the the bad bacterias, which cause infection to go in the blood because of your work in the mouth and damage the other areas in the body because they are responsible for it. So, fixing the tooth in a meticulous way is not your primary concern in such patients. In such patients, the only concern is to remove the source of infection. Because what is the point of you doing a meticulous root canal treatment, giving the most beautiful of the post and core, and yet some amount of bacteria is left inside? That is going to go and damage his heart and cost his life. Then was your meticulous treatment on the tooth be any worth it? No. So sometimes in a lot of cardiac patients, even as a pediatric dentist, when we treat children who are going to undergo cardiac surgeries, open heart surgeries, congenital defect repairs, and even if we see a tooth which has good roots but caries in the pulp, we choose to extract it because heart is more important than that milk tooth. Even though the child is 4 years and 5 years, and if he was a normal child, like with a normal heart, we would have taken pulpotomy or pulpectomy with crowns. But we don't do that. We just extract because We don't want even that 1% of focus of infection being left behind. So, whenever you have a patient with a systemic condition, the main concern of you as a dentist should be of the overall well-care of the patient, and dental thing becomes secondary. In an otherwise healthy patient, then you can be focused on the dental needs to make it primary and do the most beautiful job that you can. So understand this difference and do not compare the treatment of a tooth with caries the same way as you would in a normal patient. You have to think about systemic factors first. You understand that? So, and here, like I mentioned, my answer is remove any source of infection. Understood? Post-operative extraction instructions are necessary regarding the risk of endocarditis, which statement is wrong. Alert for signs and symptoms for endocarditis. That's true. Now, see, you will tell the patient the signs and symptoms of endocarditis only if you know them, right? Now you know, we discussed, right? The symptoms may be of acute onset and progress rapidly. Yeah, there only itself that word acute is wrong. It should be subacute. So whenever I see something like this, bang, my answer is there. But anyways, let's see the other options. Endocarditis caused by oral streptococci is usually of an acute type. No, it is subacute type again. Patients with endocarditis of a prosthetic valve progresses to heart failure more rapidly. That's true. That's true. So if I have to choose between option B and C, let me read the option B more. So the symptoms may be of acute onset and progress rapidly or persist for weeks or months before the cardiac signs develop. That's true. That's true. So let's go back to this option again. Yeah, the symptoms may be of acute onset and progress rapidly or persist for weeks or months before cardiac signs. That's true. But endocarditis caused by oral streptococci is of acute type. That's false. That's straight away false. So subacute type, if they would have written, then my answer of C would have been like that would have been a true statement. I wouldn't have chosen that. But since they mentioned it as of an acute type, I'm going to choose that as a wrong answer, meaning which statement is wrong. That is my answer, that it is of subacute type. So I hope this is clear. And option B is very important for you all to understand that the symptoms that will develop, they can persist for weeks or months. Imagine how much the patient is going to suffer. And that's why it is so important for you to give the antibiotic prophylaxis in such patients before the start of the treatment. But again, the article which I read out here, I mean, this is me talking as a practitioner, one practitioner to another after reading articles. Uh, so far, all the cardiac patients that I have treated and given the prophylaxis, by God's grace, they didn't develop any symptoms. But the article mentions there is significant, what do you say, ambiguity that how much these antibiotics are useful, we don't know of it. We give it as a precaution for sure, but do they actually help is something that needs to be investigated more. So in the summary, yeah, I mean, something like that was written, and even in the other articles that it's biased. That no study is conclusive that giving antibiotic like really helps. So you should, but in case you forget, just pray that nothing happens. But be very careful in understanding while treating systemic condition patients. So I hope this is clear. And yes, it's my off day today, so I'm going to sit and accept all the requests over the Facebook. For all the new candidates who are watching my video for the first time, there is a Facebook page called as Target ADC. You have to come in, you have to give your request. I accept it like once a week. Yeah, last week I could not. A lot of things were going on. Now I'm going to sit and accept all the requests, and I'll be sending out an email to you all. Yeah, read it. Hope it helps, and you can always reply me back. And it's always good to listen to your comments. Read your comments. Yeah, I don't listen to them, I read them. Yes, it's always good to read your comments. So please write it on YouTube. And yeah, yesterday after a long, long time, I played badminton for like 3.5 hours. Exhausted. We had kind of a tournament, and badminton is my first love of my life. If my parents wouldn't have like coaxed me in the medicine field, which I also love, like I love studying. You know that by now. I'm a nerd, right? But yeah, badminton was something which was so good. In my school days, I remember I used to play so much. I had gold medals in badminton, straight 7, 8, 9, 10, all the four grades, singles and doubles. I played it with so much of passion. And then 11th and 12th happened, like just had to study, science, typical medical student. And then when I went to college, could not keep up with badminton because my college was like, how I used to travel to my college? Yeah, that's a very nice story. Oh my God, I don't know how I did it, but I used to stay in Malad in Bombay, and all those Bombayites will know what I'm talking about. And my college was in Navi Mumbai at that time. So Malad to Dadar, changed the train, Dadar to Kurla, changed the train, Kurla to Navi Mumbai. That's uh, Juinagar station, yeah. It took a proper 1.5 hours from my home to the college if I didn't miss the train. If I missed a train, then additional 20 minutes. And I used to literally run with those thick books across the platforms. Because though Malad to Dadar, I had trains every 10 minutes. The problem was from Dadar to Kurla, and major problems from Kurla to Juinagar, because those trains were at the distance of half an hour. So if you miss one train, bang, half an hour you're standing on the platform. And yeah, it's crazy it was. And the same journey back, and the college is from like 8 to 4. So 6 o'clock I used to leave home. I used to be home by 6, 6:30. So tired. And then you had to study so much. Dentistry is not that. I mean, and I, being a nerd, I wanted to study everything. So uh, yeah, no time for badminton. So when I came to Dubai so many years later, uh, I started playing again, and I'm so glad. Badminton is so sought out after sport here, and we have so many beautiful indoor courts and amazing people who play like good level badminton, not the beginner level. So yesterday we had a tournament of sorts, and we ended up playing like 10 matches. Like we went to the finals, of course. I get a little competitive, there. And then, wow, my body was aching so bad today, but there's so much happiness in my heart that I played badminton for such a long, long time. Yeah, but also it made me feel old because my muscles are aching now. But seriously, I sometimes feel I'm done with this working. I just want to go back and like rigorously train for badminton like some professional and just give it all, because if left it to me, and if we had money, if my parents had money, I would have told them, let me be just a sports person, let me play for the country, I'll do everything that it takes. Yeah, but they said go earn it yourself. So yeah, here I am. Hopefully I'll get a chance to yeah, train professionally and do something nice. That's one thing which I really, really want to do. So, yeah, see you next time and hope this video helps. Bye bye.